Hi, everyone, and welcome back. My name is Tina Costa, and I'm one of the directors, at the PHSA Office of Virtual Health, continuing to be your host for these virtual sessions. My pleasure to welcome or re-welcome you to day 2 of the 2023 Digital Health Forum. For those of you joining our virtual circle, we encourage you to share in our collective gratitude for the opportunity to come together from many traditional, ancestral, and unceded territories of BC First Nations. As we continue to engage, learn, and collaborate in the realm of digital health, let us give thanks for the privilege to do so on these beautiful and sacred lands, and may our discussions contribute to a future where Indigenous voices are uplifted and the principles of reconciliation guide our path forward. I now have the pleasure of introducing our next presenter, Matthew Wiens. Matthew is an assistant professor in the Department of Anesthesiology, Pharmacology, and Therapeutics at the University of BC and an investigator at the Institute of Global Health at BC Children's and Women's Hospital. He is a global health epidemiologist and public health researcher dedicated to improving the transition between hospital-based care and community-based care among children with sepsis using data-driven decision support systems. His work in Uganda over the past 12 years led to the recognition that as many children die within the first few months after discharge as died during the initial hospitalization period. Working alongside the Uganda Ministry of Health and his colleagues in Uganda, he developed the Smart Discharges program to improve the hospital-to-home transition following admission to sepsis. Please join me in welcoming Matthew for his talk, as it says here, Improving Discharge Care Using Readily Available Clinical Data. Matthew, sorry.
Thank you, Tina. It's my pleasure to be here today to talk a little bit about some of the work that I've been doing over the last 12 or 14 years or so. Without further ado, I thought we would just start. We're a few minutes behind schedule, so I'll try to get through this within a reasonable time frame. So what I do, we have sort of called Smart Discharge, which is essentially a way of using data to more smartly discharge children after their hospitalization period. And my work is primarily focused in resource-limited settings in Africa. Many of you will have possibly seen these world mapper slides, which essentially reshape geographical boundaries based on particular issues. So in this case, they've reshaped geography proportional to under 5 mortality. You can see that the global burden of under 5 mortality is borne primarily in Africa and parts of Asia. And really, this is what has led me to do the work that I do, which is focused on child health related issues in East Africa. If we were to look at the burden of the lack of data, it would look fairly similar. I couldn't find any slides to show the paucity of high quality health data, but it would look similar. Although we all talk about how we have poor access to high quality data in all areas, this is especially felt in resource limited areas. And this is what some have called health data poverty. And essentially, it's defined as the inability for individuals, groups, or populations to benefit from a discovery or innovation due to its insufficient data that are adequately representative. Given that about 1 out of every 5 people on this planet are from Africa, it certainly is true that Africa does not represent 1/5 of the global health data supply. So in addition to all of the health-related problems, we also have an issue with the lack of high-quality health data to help inform effective solutions to care. If you look at how children move through a healthcare system in sub-Saharan Africa or in places like Uganda, where I primarily work, we can see that there's many barriers along the pathway of care. These could also be seen in high-income settings like Canada, but the focus here is specifically on low-income settings. So at the community level, there's delays in recognizing the need to seek care. Even once that need is recognized, there can be delays in travel. This can be due to infrastructure barriers like roads or geographical barriers like floods, for example. Even once facilities are reached, there's delays in receiving high quality care at the facility. But the area that I particularly want to focus on is the issue around what happens to children after they leave hospitals. There are significant barriers to ensuring that the gains made during an initial hospitalization persist throughout the first several months after discharge. We've done several systematic reviews on the topic of post-discharge mortality, and we just recently finished one which will soon be published. And we have shown that the rates of mortality within 6 months of discharge range from between approximately 1 in 30 children to as high as 1 in 12 children, based on some underlying subpopulation. So you can see here that, for example, children who are malnourished have about a 1 in 12 chance of dying within 6 months of discharge. This is very, very high. And if we compare the rates of post-discharge mortality to the rates of mortality seen during an actual typical hospitalization, we see that the rates of mortality during the post-discharge period are largely similar to the rates of mortality during the acute in-hospital period, although there's some differences between the different kinds of causes for admission. But generally speaking, there's a significant burden of post-discharge mortality. And I think this is one significant priority that has not been sufficiently addressed in global health. So one of the issues is that we don't have really good data on this problem. So the limited data that we have is from actual research studies. If we were to answer this question of post-discharge mortality or post-discharge readmission in a resource-rich setting, like Canada, for example, all the data exists. So we know of children who die, vital signs are collected, vital statistics are collected routinely, and that can be easily linked to prior admission. So this data is readily available in resource-rich settings, but it's not readily available in resource-poor settings. So we undertook some research studies to better understand this issue in a Ugandan context. So we did several large studies, but more recently, a significant study looking at post-discharge mortality in Uganda. We looked at 6 hospitals in 4 cities in Uganda. And the purpose really was to, number one, build a prediction model to allow us to better assign risk based on key data elements. So are we able to identify the children who are at high risk of a post-discharge event, like mortality, for example? And secondly, we wanted to understand the basic epidemiology of post-discharge mortality. And thirdly, we wanted to also use this data as a baseline to compare to an interventional period where we have an intervention focused on risk. So where children essentially get different intensities of post-discharge care, specifically based on their individual risk of mortality over the next 6 months. Does this approach improve mortality among children? In this study, which was approximately 12,000 children, we collected data at admission. We collected data such as basic demographic data, clinical data, social economics data, and other social data, some basic laboratory data. We collected data at discharge, such as what their diagnosis was, what their disposition was. Was it a discharge to a higher level of care? Was it a routine discharge? Was it a discharge against medical advice? And then we collected data up to 6 months after discharge. So we captured things such as health seeking, vital status, readmissions, and for those that died, we captured data on the causes of post-discharge death. We used well-trained research assistants, typically nurses, to do all of our data collection at all of our facilities that we worked in. We did this work over the course of about 5 years. Essentially what we found was among the approximately 6,000 children that we enrolled in these 2 different age categories, we found that for children who were 0 to 6 months of age, approximately 7% of children died during their initial admission, and 7% of children died within 6 months of discharge. Likewise, for children who were 6 months to 5 years of age, approximately 4% of children died during the initial admission, and approximately 4% of children died during the post-discharge period. So essentially what we're seeing is that we have as many children dying after discharge as dying during hospitalization. And here you can see our data according to different age strata. So you can see we have less than 2 months of age, 2 to 6 months of age, 6 to 24 months of age, and more than 24. And we see, generally speaking, that the younger children have higher risks of dying. I think almost more importantly, we see that most of the deaths that occur after discharge actually occur outside of a readmission. So the children either often die at home or they die on the way to seeking care. So between those two different scenarios, that's about 2/3 of all deaths occur outside of a facility setting. And this is a major problem because these children should obviously be receiving high quality care at a facility. So with a better understanding of epidemiology, we then sought to build predictive algorithms to identify the children who were at high risk of care. Essentially, we wanted to build a digital clinical decision support tool that could help guide care. So we took our data that we had that I just mentioned, and we added it to some prior data we collected from prior studies and to subsequent data that we collected in subsequent studies. And in total, we had something like 8,000 plus children who we used to develop these clinical prediction algorithms. And the outcome rates are virtually the same as in the last study, although we have slightly more patients to do this modeling experiment with. So we used very basic, easy to collect admission parameters, only admission parameters, to build a clinical decision, a clinical prediction model. So we wanted a model that can allow us to divide children into different risk categories, so we can do something different based on the different degrees of risk. And we built separate models for the younger children under 6 months of age and the older children, because we thought, and we know that there are differences in the causes of mortality and different physiological parameters that would be important to different age groups. So we built models and they seem to perform reasonably well with regards to predicting risk. So we see AUCs in the range of 0.75 plus, which is pretty reasonable discriminatory capacity for differentiating different amounts of risk. Most people who I talk to about this are curious to know what kinds of predictors are included in a model. We had a very complex pathway of getting to the predictors that we do have, but we wanted very simple models that used few variables. So for us, we wanted models that used less than or equal to 8 easily collected variables. And we used many different, and we built several different models to accommodate the fact that not every scenario will have every kind of variable available. So different hospitals may not have certain availability of certain variables like hemoglobin or SpO2, for example, and they need to have different models that can accommodate those situations. So the variables that we used in the under 6 month old group included basic anthropometry characteristics. So we have mid-upper arm circumference, we have duration of illness, age, some neonatal things like jaundice, feeding, SpO2, and you can see them there. For the older kids, they were largely similar in terms of the kinds of variables. It's very much based on anthropometry. In addition, we had hemoglobin as an important variable, as well as a few other variables like level of consciousness and respiratory rate. Essentially, what these models allow us to do is to divide children into different risk categories. Now, the thresholds that we choose are rather arbitrary, and they ought to be based on the contextual factors relevant where we're deploying them. So in some facilities, perhaps the thresholds should be higher because they have very few resources and they only want to find the highest risk children where they can apply a different kind of post-discharge care plan. For some that have higher amounts of resources, the thresholds can be lower. But we developed sort of a generic scenario of 4 different risk thresholds. And you can see here that the different age groups have different results. So here we can see that in the 6 to 60 month category, for example, there are low, moderate, high, and very high. And you can see there the proportion of children that fall into that group. So for these older children, It's about 15%, 50%, 20%, and 10%. So that's the proportion that would fall into the different groups. And you can see on the right side, the rate of mortality in those groups ranging from 1% to 18%. So you can see a vastly different division of risk, which could then lead to a vastly different division of the intensity of follow-up, for example, that could be applied during the post-discharge period. We paired the knowledge of risk with a particular action based on the risk, and we call that the Smart Discharge process. So essentially the way that this works is that children would arrive at the facility, be admitted. The admission characteristics allow us to determine a risk level. That risk level then determines the intensity of the discussions that occur, so ensuring that the mother is well aware of the vulnerability of her child during this transition period and equipped to care for this child well during this process. It also ensures that those particular children who are at high risk get a more frequent follow-up visit. So we use SMS messages, for example, to allow the facility to connect with the mother, to schedule these follow-up visits, and then ensure that that those children get the follow-up care that they need to monitor their child for a robust recovery. We implemented this into a package, and we evaluated this, and we saw that we can reduce mortality by about 16%. This was in the interventional phase of the study I just mentioned. We haven't quite finished doing all of our follow-ups. This is the preliminary results. We hope to have this done by early next year for publication. But we're seeing a mortality benefit. So the question is, well, so now what do we do with this package? So we want to obviously implement this more broadly. And in addition to the 6 facilities that we did the research in, we've also started trying to implement this with different models of care in our sort of what we call our expansion phase. So we've engaged with about 19 different facilities in Uganda, and there's certainly, and there was significant enthusiasm from these facilities to implement a post-discharge care program. And there are sort of 3 models that I want to talk about with regards to how we use this digital health innovation to improve care for children in Uganda. So the first model is what I would consider the most basic model, and that essentially uses an app that we developed ourselves. That app then provides the information to the health worker about the risk. So the health worker enters in the different parameters, they get a risk score, and that essentially allows them to change the pathway of care based on the risk score. The way that it's implemented is that we have sort of a data hub essentially, and that's sort of the information from the app is relayed to that data hub, and through that data hub, there is an SMS message, a referral that goes to the village health team member. So in these regions in Uganda, they have community health workers that are distributed across the country. In each village, there are health workers. We have the data for those health workers. And essentially, a discharge is referred to that health worker, and they get different information based on the degree of risk. The patient also gets information through an SMS message, and the data from the admission is then stored on this on the server essentially, and that same server is used to relay that message back to the health worker and to the patient. That's one of our models. The other model is, which is a more preferable approach when it's available, is to integrate into an EMR system. So we have a partner in Uganda called Streamline, and we've integrated our work into their EMR system. So all passively, so all the data is passively captured through the EMR, through the intake. The person doing the entry doesn't know that it's being used in a model because it's routine data that would be collected anyway. With that, the data goes to the server for that particular EMR, and the same process happens as it happens with our own app, but now this is all passive. That server then initiates the text message pathway, and it essentially provides information to both the patient and the village health team member. The third way is the most complex way, but the most ideal way. And we haven't actually implemented it yet. We've built it all. We haven't yet pushed the go button. And that's using what we call the e-community health information system, which is a platform developed initially by Medic Mobile, which is being implemented across several countries in Africa. Essentially, this is a platform that is implemented at the community level by community health workers. So we have our facilities capturing the data at admission through whatever means they have. So that could be through an EMR system or through a tablet-based platform like Para app, for example. That information goes directly to a government server. This is through DHIS2. And that server is the central repository of health data for the country. That server then links with the village health team member or the community health worker. Not only that, that community health worker then can relay information on follow-up back to DHIS2, which then can relay information back to the facility, providing sort of a closed loop of information so that the health workers who discharge the children can actually know what happened to those children. It can also aid in subsequent referrals if that child is found to be ill again and needing more higher intensity care. So those are our three sort of models we've implemented so far or are about to implement. We've developed a whole series of educational materials and training materials. So we have a 3-day post-discharge training program that we've developed alongside the Ministry of Health, as well as lots of educational and counseling material. Essentially, what we wanted is we want the data to be used in multiple different facets. So number one, we have our data and we want that to inform policy and funding. So we want better policies around discharge care, and we want the data to show us the evidence that we need to give to the policymakers to improve policies. Also, the data can be used for surveillance and updating, building better models. And then, of course, at the facility level for quality improvement initiatives. Not only are we doing this work for children who are being discharged after an acute illness, we're also working on this in different areas. So we're doing work in Rwanda now to validate our models, which we've just finished, which is looking really good. We're also doing this work in mother-baby dyads following hospital delivery. So how do we improve the provision of postnatal care after delivery for mom and baby? Data can help us do that better. And we're doing this also in refugee settings. And now we're extending our work to children who are over 5 as well. So a lot of things happening. We're trying to essentially improve pathways of care after discharge. And that concludes my presentation. I would love to engage on any subsequent questions. Thank you.
Matthew, thank you so much, not only for your incredible work in child health internationally, but for highlighting that significance of data availability and showcasing how a comprehensive, digitally enabled discharge experience, especially with a community presence, creates such incredible benefits and better clinical outcomes. This was a really powerful story. We do have 2 questions, but I'm going to combine them because they're sort of on the same theme. And so the question really is around, do you have plans of translating this into a BC clinical setting?
Yeah, so that's a great question. In fact, I just had a conversation just a few minutes ago with the head of pediatrics here at BC Children's Hospital and relaying the relevance of these ideas to a setting in Canada. We would call this sort of reverse innovation, wouldn't we? Where we take some ideas, lessons learned from a global health context and applying them to our own. We've done some preliminary work on this very topic from children who are coming from rural and remote communities to tertiary centers. So we looked at children who have been admitted in Prince George and at BC Children's here in Vancouver, who have come from rural and remote areas. And we looked at their readmission rates, and they're substantially high. So when children are repatriated back home, we want to know who those high-risk kids are so we can actually provide the best kind of care to prevent them from having to make these very difficult and expensive trips back to these tertiary centers. So yeah, there's huge relevance here. The issue is less mortality and more readmission. But I think that predictive analytics and the fact that we have the data, it's hard to get at actually, but we have the data. And of course, the funding is also the big thing, right? I mean, there's just very little funding for these kinds of things, but I think that's changing.
Incredible. Thank you once again, Matthew, for joining and for such a powerful presentation. We will close the session now and have the poll come up for a bit of feedback. We will invite you to our next 2 o'clock session, which is entitled Data Protection and Legal Obligation. We hope to see you there, and you can navigate to that session by clicking on the title on the panel on the left-hand side of your screen. Again, Matthew, my apologies. Really appreciate your time today.
Thank you. Bye.